Investigations will review the ECG, will show prolonged QT interval and an appearance of a U wave. Lab investigation of the serum will indicate low potassium level. That is potassium level below 3.5 milliequivalents per liter. Clients will also show arterial and ventricular arrhythmias. In the management of hypokalemia, it is imperative to treat the underlying cause and subsequently administer supplements through infusions. Because of the low therapeutic index of potassium, it is unwise or it is fatal to give KCl, potassium chloride, directly into the bloodstream. And as such, it will have to be added to infusions, such as normal saline or 5% dextrose or any isotonic infusion during the administration. Causes related to diarrhea or vomiting, that ensures rapid depletion of electrolytes, will also have to be treated to ensure that hypokalemia is properly managed. Hyperkalemia. Hyperkalemia occurs when blood potassium level exceeds 5 milliequivalents per liter. 5 is usually used. However, you may see in some textbooks 4.5 to 5.0 milliequivalents per liter. As I said, dietary sources of potassium constitutes about 50 to 150 milliequivalents per liter of potassium. And as such, at all times, a functioning kidney or a functioning excretory system is needed to excrete excess potassium. Where a client has kidney nephropathies or any kidney disease, that affects ultrafiltration, selective reabsorption, or tubular secretion, it can result in hyperkalemia. Remember that the body takes in about 50 to 150 milliequivalents per liter of potassium through diet on daily basis, and hence regular diet should ensure that a client has adequate amount of potassium and adequate amount are excreted. However, when a client starts to experience kidney insufficiencies, hyperkalemia is probable. Diabetes, that may also result in kidney insufficiencies like chronic kidney disease, may also promote hyperkalemia. Where sugar or glucose lines the kidney's tubules, it may result in improper ultrafiltration or improper selective reabsorption and or improper tubular secretions, because glucose lines the cells that ensure these actions take place, and hence diabetes can also lead to hyperkalemia. Hyperaldosteronism and Cushing syndrome can lead to hyperkalemia. Increased intake of potassium in diet, coupled with a kidney disease, may result in hyperkalemia. Excessive use of certain drugs, such as potassium-sparing diuretics, may result in hyperkalemia. An excess amount of hematocrits. You know, we've already said that hematocrits represent red blood cells and white blood cells. And we've also stated that potassium is most abundant within a cell. Where a client has high amounts of potassium or high amounts of cells, it means that each cell contains equal amount of potassium. And hence, in a case where the cells begin to rapidly break down, for whatever reason, potassium is released in the blood, and the client may begin to experience symptoms of hyperkalemia. Signs and symptoms: you may see a flat P wave and peaking T waves on the EKG. EKG will also look sinusoidal because there's insufficient time between depolarization and polarization, or in simple terms, muscle contraction and muscle relaxation. And therefore, you will see that the EKG looks relatively abnormal. Instead of looking like the normal QRST wave, it will look sinusoidal. That is, it goes up and goes down like a pendulum. Cardiac arrhythmias may also be observed in clients with hyperkalemia. Increased heart rate may also be seen in clients with hyperkalemia. Muscle cramps and spasms because of the abundance of potassium in smooth muscle may result in hyperkalemia. Calcium. Calcium acts inversely with phosphorus, saying this to mean that whenever there's high amount of calcium in the blood, there's no low amount of phosphorus in the blood. And whenever there's high amount of phosphorus in the blood, there's low amount of calcium in the blood. And hence, the signs and symptoms, you would see that they relate one way or another, or they go together because of their inverse relationship. Calcium acts as a gatekeeper for action potential, essentially blocking or permitting action potential. So when you have low amount of calcium in the blood, there's high amount of action potential that can take place. And when you have high amount of calcium in the blood, there's relatively low amount of action potential that can take place. As you come across the signs and symptoms, you'll begin to see that low amount of calcium will lead to spasms because of the action potential that has been allowed. And high amount of calcium may resist spasms or may resist movement completely. And hence you will see that this is due to action potential. Calcium is needed for muscle contraction, oocyte activation in bone formation, activation of clotting factors in blood clotting, and the strengthening of bones in the blood. Is 9 to 10.5 or 11 milligrams per liter, or 4.5 to 5.3 milliequivalents per liter. To remember this, I usually use the abbreviation CA911. Call 911 when you have emergencies. CA911 or 10.5 doesn't really give it a ring, but 911 does, for easy remembrance. Calcium is located predominantly in the bones and in the teeth. About 97 to 99% of calcium is located in the bones and in the teeth, and 1 to 3% of calcium is located within smooth muscle and in circulation. When there is low amount of calcium in the blood, that is calcium levels less than 9, what happens is that calcitonin is released from the parathyroid gland to break down bones and oocytes to release calcium into the bloodstream. And hence, the signs and symptoms that may occur. Hypocalcemia may be caused by vitamin D deficiency. Vitamin D deficiency because vitamin D helps in the metabolism of calcium. Hypothyroidism, thyroidectomy, hypoparathyroidism. Hypoparathyroidism meaning that low amount of calcitonin. And low amount of calcitonin means that whenever calcium is inadequate in diet or inadequate in circulation, there is nothing available to break down calcium stores, which are in bone cells, to ensure that client has enough calcium within the blood or for body function. Thyroidectomy may result in unfortunate, or let me put it as complications, such as removal or puncture or destruction of the parathyroid gland because of its close proximity to the thyroid gland. And as such, whenever thyroidectomy takes place, a client is at risk of the parathyroid gland being destroyed, and hence thyroidectomy can be a cause of hypocalcemia. Hyperphosphatemia. As I started this lecture with, I stated that calcium enjoys an inverse relationship with phosphorus, and hence whenever you have high amount of phosphorus, as stated in hyperphosphatemia, you can experience low amount of calcium, that is hypocalcemia. Pancreatitis may also result in hypocalcemia. And of course, pregnancy, when the baby starts to pull on the calcium within the mother's blood, and calcitonin destroys as much of oocytes as possible, and there's none left to destroy. The mother would be faced with an unfortunate circumstance that may result in hypocalcemia and may have to increase dietary intake of calciums. Signs and symptoms of hypocalcemia includes a positive Chevostic sign and a positive Tresor sign, tetany, twitching, and muscle spasm. Positive Chevostic sign means that in a client with hypocalcemia, whenever you touch the cheek, the client will experience spasm on the eyes, around the eyes, and on parts of the face. How you keep this in your head is Chevostic, CH, which represents a cheek. Is the name of a famous person that was used to represent this symptom. And fortunately, it rhymes with cheek. So you see Chevostic, you remember cheek. Whenever you touch the cheek, you begin to see facial twitching. Tresor sign means that whenever you inflate a cuff to check a client's blood pressure, or whenever you apply a tourniquet on the client's arm for a relatively longer period, the client's fingers begin to spasm. As was stated at the beginning of this lecture, calcium is responsible for controlling the action potential occurring in the body. Low amount of calcium means that body action potential happens at a high rate, and hence body function is at an alarming rate. This means that whenever simple pressures or pressure is applied to any part of the body that may have been tolerated previously, action potential rapidly increases, and hence you see the spasm on the client's hand. The client may also experience tetany and twitching, as well as muscle spasm. These are all inferred in action potential. Clients may also experience numbness and tingling sensations in the fingers and in the lips. The client may experience decreased heart rate due to the action of calcium or the involvement of calcium in the polarization of the heart together with sodium, and hence decreased heart rate or bradycardia may be seen in cases of low amount of calcium. A client may also experience GI upset due to the presence of calcium in smooth muscles. Hence, GI upset may also be seen in cases of hypocalcemia. Take note that whenever you have high amounts of phosphorus, most of these signs and symptoms may also reoccur because high amount of phosphorus goes with low amount of calcium. For your nursing management, what you want to do for your client is to increase the amount of calcium in the client's diet. So foods that ensure high amount of calcium, like bones and the rest, may be used to manage hypocalcemia. You would also want to provide a calcium supplement for your client, ensuring that he has adequate amount of calcium. Hypercalcemia. In hypercalcemia, what you see is that client calcium levels are far above 10.5 grams per milligram per liter within circulation. Causes may include bone cancer. As has been explained, the action of calcitonin ensures that bone stores or oocytes are broken down whenever you have calcium depletion in the blood. When a client has bone cancer, the rapid proliferation or the rapid growth of bone cells means that when calcitonin is released into bloodstream, calcitonin now has a lot more bone cells to break down. A lot more bone cells to break down means that a lot more calcium in circulation. Hyperparathyroidism. As has already been explained, the parathyroid glands are responsible for calcitonin production. Calcitonin is responsible for the breakdown of cells, and hence in a case where you have high amount of parathyroid hormones in circulation, calcitonin also becomes highly concentrated or is released in high amounts into the bloodstream, and hence a client can experience hypercalcemia. Hypophosphatemia. As has already been explained, calcium enjoys an inverse relationship with phosphorus, and hence low amount of phosphorus can result in hypercalcemia. Long-term steroid use ensures that the amount of cortisol within the blood is in excess, and hence hypercalcemia may be experienced by clients. Signs and symptoms of hypercalcemia may include constipation. Constipation is because of the abundance of calcium cells or the presence of calcium cells in smooth muscles and hence the GI tract. In hypocalcemia, a client will experience GI upset. However, in hypercalcemia, a client will experience constipation. Kidney stones are formed as a result of high amount of oxalate within the blood stream, and therefore whenever you have high amount of calcium, which can solidify and after a long period form sedimentary particles, it can easily result in kidney stones. It's important to note that kidney stones or kidney crystals may break by itself at any given point in time as a result of increased hydration, and therefore kidney stones usually resolve by themselves but may produce a lot of pain in the client. A client may also experience weakness because action potentials are not allowed to take place. As we said in the beginning, calcium acts as a gatekeeper for action potential, and therefore when you have high amount of calcium, action potential does not take place as it's supposed to, and hence you see a lot of weakness in the client. Decreased tendon reflexes is also implicated in action potential decrease. For your nursing management, what you want to do for your client is to increase his intake of phosphorus. Increased intake of phosphorus will ensure that the high amount of calcium is decreased. Serve IV fluids as prescribed by physician. serving IV fluids would ensure that the patient's output, urine output, is increased, sweat output is increased, and salivation is increased, and hence excess electrolytes may be decreased through these avenues of excretion. And treating the underlying cause may also be essential in the management of hypercalcemia. Magnesium. Magnesium is relevant for nerve and muscle function, bone formation, and other biochemical reactions. Magnesium has a normal range in the body of 1.5 to 2.5 milliequivalent per liter. Causes of low hypomagnesemia or low amounts of magnesium in the blood include GI losses, that is through diarrhea or through excessive vomiting, alcohol abuse, and prolonged use of diuretics and laxative. These constitute iatrogenic causes. Malnutrition, where there is low intake of magnesium, may also result in hypomagnesemia. Signs and symptoms may include constipation, hypertension, confusion, dysrhythmias, and decreased reflexes. And the management of low amount of magnesium in blood circulation, what you might want to do is to serve magnesium oxide pills as ordered by your physician. You may also want to include high amounts of magnesium in foods or in diet. And you may also require that client rest in severe cases. Client resting is as a result of the signs and symptoms experienced and how you want the client to build up the stores of magnesium within the blood. And as such, cases relating to dysrhythmias and other symptoms may require bed rest. Hypermagnesemia. In hypermagnesemia, you may observe levels of magnesium far above 2.5 milliequivalents per liter. Note that magnesium doesn't really it has a high therapeutic index, and therefore in questions that hypermagnesemia are implicated, you will see that magnesium levels will be around 5.3 or 5.0 or 4.0, far above the normal range, and that will tell you that this is hypermagnesemia. It is caused by excess intake of antacids and laxatives, which contains magnesium. That is the primary cause, or for most of the cases we would see. In most of the cases you will see, whenever the antacid contains magnesium or a drug of any kind contains magnesium, these Nugel O, these drugs used to treat peptic ulcer, all of them containing magnesium. As it contains magnesium and you take them in excess, you are at risk of hypermagnesemia. Symptoms may include lethargy, hypotension, muscle weakness, respiratory arrest, and cardiac arrest. To nurse these symptoms, what you may need to do is to provide bed rest, ensure adequate fluid in the client, and serve drugs as prescribed by a physician to reduce the amount of magnesium within the bloodstream. Fluid balance. A person's total body weight is as a result of 2/3 of the fluid within the person's being. Fluid balance involves the assessment of the level of fluid within a client or the hydration status of a client. It mainly involves assessing the intake and output levels to determine intake of fluid and the output of fluid from a client to determine dehydration or overhydration of a client. As a result, fluid balance includes assessing fluid volume deficit in dehydration or underhydration and fluid volume excess in cases of overhydration. Fluid volume deficit refers to hypovolemia or dehydration occurring in a client. In fluid volume deficit, fluid output is usually greater than fluid input. Causes may include GI losses as a result of vomiting or diarrhea, excess use of diuretics, bleeding or hemorrhaging, excess diaphoresis or excessive sweating, diabetes insipidus that results in excessive urination and excessive thirst, and kidney disease that promotes uncontrolled micturition or uncontrolled urination, results in fluid volume deficits. Symptoms may include a low blood pressure because of the decreased cardiac output. Low blood pressure or low volume of blood means that blood is not reaching everywhere within the body as the body expects to. And as a result, the heart will be forced to beating faster to ensure that blood reaches all parts of the client's body. And it beating faster increases the heart rate, and that is why we have tachycardia. Increased heart rate means that the amount of oxygen that are carried by the red blood cell will have to correspond with the heart rate, and therefore a client will experience tachypnea or increased respiratory patterns. Clients may also experience a weak threaded pulse because of how fast blood is moving through the veins. A client may experience thirst because there is a need for the client to drink in water or to have infusions taken in if he is unconscious. Therefore, thirst would be a sign and symptom that will occur because of fluid volume deficit. A client will also experience a very dry mucous membrane and oliguria or decreased urinary output. Concentrated urine may also be seen in a client with fluid volume deficit. Decreased skin turgor, fatigue, high body temperature, loss of skin turgor, decreased capillary refill, and flat neck veins may be seen in a client with fluid volume deficit. Flat neck veins show because the amount of blood will also correspond with the hydration status of a client. And if you have very low amounts of blood within a client's body, you will see that the neck veins will not show at all and will be very, very flat. Capillary refill will also be decreased because blood flow to extremities are limited. And this limitation will mean that whenever you press on the capillary bed on the peripheries, the refill time will be a little longer than normal. Loss of skin turgor because, as you all know, fluid is involved in the maintenance of the skin and its appearance. A well-hydrated body often correlates with a healthy skin and a well-hydrated skin. And therefore, when the client has deficits on the skin, what you see is that the body will begin to shut down blood supply to non-essential places. And non-essential places mainly constitutes the peripheries. And loss of blood flow or decreased blood flow to these peripheries may result in low amount of fluid in these peripheries and therefore decrease or loss of skin turgor. Lab investigations will show an increased BUN blood urea nitrogen, increased hematocrits, increased blood osmolarity, and increased urine specific gravity. As you all know, from the beginning of this lecture, we explained that hematocrits are about 45% of blood cells, 45% of blood within a normal human being. When you have low amount of fluid in the bloodstream or fluid in the body, what happens is that the plasma, which is about 55%, decreases, because plasma is where most of the water is. And when the level of plasma decreases, what you see is that the hematocrit level also increases, because if it is not diluted, then it is concentrated, and hence you have high amount of electrolytes within the same system. Increased blood osmolarity would also be experienced by your client. What you want to remember is that osmolarity is the same as concentration, and therefore when you have decreased amount of plasma, what you see is that hematocrit levels will also increase, and that will influence the concentration of the blood. What you also see is that urine specific gravity will also be greater than 1.08. This is because of the increased concentration of your urine, and therefore you would see that your urine specific gravity, or the client's urine specific gravity, will increase in cases of fluid volume deficit. In your management, your chief concern may want to be fluid replacement. So you would serve a lot of fluid to your client, and usually this fluid may include intake of oral rehydration solution, or ORS. You may want to monitor the client's weight daily, because the weight is included or is inferred in the fluid hydration status, and therefore monitoring the client's weight may be essential in deficit management. What you also want to monitor is the client intake and output strictly, and you want to notify the physician if urine is less than 30 ml per hour. You may also need to serve oxygen if dehydration is severe and the client's respiration begins to suffer, or the client goes into respiratory distress. The major complication of fluid volume deficit is hypovolemic shock. Other vital organs, such as the kidneys and the heart, may also experience complications. Kidneys may begin to show signs of kidney disease or nephropathies, and the heart may also begin to show signs of arrhythmias or heart failures. Fluid volume excess. When we talk about fluid volume excess, what we are saying is that fluid, or a lot more fluid, is retained in the body after the intake. That means that fluid input far exceeds fluid output. And this leads to increased cardiac output, because there's a lot of fluid within the blood and there's a lot of fluid in circulation, and therefore your client will begin to experience increased cardiac output and is at risk of circulatory overload, or may experience circulatory overload. Causes of fluid volume excess include heart failure, extended use of corticosteroids, kidney dysfunction, IV therapies, blood transfusion, liver cirrhosis, burns, and excess salt intake. Signs and symptoms may include hypertension, tachycardia, tachypnea, a rebounding pulse, ascites or edema, dyspnea, crackles, and distended neck veins. Why you would experience hypertension is that hypertension is as a result of increased peripheral resistance and increased cardiac output. What you see in fluid volume excess is that there is increased cardiac output, and therefore hypertension is expected to show in a client. So the causes of fluid volume excess. Under the cause of fluid volume excess, the first cause I would like to talk about is heart failure. When the heart fails to beat at its normal rate, or when the heart fails to circulate blood at its normal rate, what you see is that you have venous stasis, the blood unable to move as it's supposed to move within the veins. And venous stasis will lead to blood leaking out of capillaries and causing blood to go into third spaces and extravascular spaces. And that will lead to a huge deficit in the urinary output as a result of third spacing, and therefore you would have fluid volume excess. Excessive use of steroids or corticosteroids can also result in fluid volume excess. Kidney dysfunction. As you all know, if your kidneys are not filtering the blood as it's supposed to, or it's not allowing urine to pass, you may have hydronephrosis and you may have fluid volume excess. Same thing applies to all kidney conditions that may result in excess blood or excess fluid in your system. For example, when you have benign prostate hypertrophy or hyperplasia, or you have any condition, prostatitis or any prostate cancer, that inhibits the flow of urine or even urine retention, you may have fluid volume excess. And so kidney dysfunction is referring to all of those conditions that fall under such headings. IV therapy use, when you are introducing fluid into the person's veins and the individual has issues with excretion, or the individual for some reason is receiving so much fluid that is overwhelming the kidneys and overwhelming the filtration rate, you may experience fluid volume excess. Same thing applies to blood transfusion. And therefore, usually in blood transfusion, a diuretic is served before blood is transfused. A person with liver cirrhosis may also experience low oncotic pressure. When we come to third spacing, we will look at the factors influencing hydrostatic pressure and oncotic pressure, and you would see how low oncotic pressure can easily result in fluid leaking out of the blood vessel and therefore leading to fluid volume excess. When a client has severe bends or bends in general, you would see that fluid will accumulate at the skin surface, which is also a third space. And this accumulation will lead to decreased urinary output, and therefore the intake will be more than the output, and we can characterize it as fluid volume excess. And when someone has excess salt intake, sodium chloride in its natural state, or salt, has a high deliquescence and a high affinity for water. And as such, increased salt intake will trap more water within the blood vessel and ensure that the person has a full volume within the blood vessel. And this full volume will lead to fluid volume excess, or increased amount of fluid within the blood vessel. Symptoms may include hypertension, and hypertension will come as a result of the increased cardiac volume or the increased amount of fluid within the blood vessel. This will put pressure on the blood vessel walls, arterial walls, and that is hypertension. One also has to note that hypertension is a byproduct of increased cardiac volume and increased peripheral resistance. When cardiac volume is increased due to fluid volume excess, peripheral resistance is also remains normal. A client is likely to experience hypertension, and therefore you see that hypertension is present in fluid volume excess. A patient will become tachycardic or will experience tachycardia as a result of fluid volume excess. This is because they had to recognize that there's so much fluid and to have to pump under higher pressure for glomerular filtration to take place. And when the heart begins to pump at a higher pressure and filtration is not taking place, what will happen is that this blood will stay in circulation and blood pressure or blood pulse rate will consistently be high, and therefore client will experience tachycardia. As a result of this tachycardia, body compensatory mechanisms will lead to we having dyspnea or the client having dyspnea. This will be because as the heart is pumping faster, the body might assume that there's a problem with the cardiac volume, just as in fluid volume deficit. And because of the assumed deficit, you would see the patient breathing fast. Also, you have to take note of pleural effusion that may take place under fluid volume excess. And pleural effusion will ensure that there is edema or there is fluid in the lungs. And because of the low alveolar space, the client may begin to experience symptoms like in respiratory acidosis. And as in respiratory acidosis, clients will begin to breathe fast and will begin to experience tachypnea. Furthermore, a client will experience rebounding pulse. This is because of the full blood volume within the blood vessel. A full blood volume, like just assume you have a water hose. Water is moving under a very high pressure, and the entire water hose is full of water. When that happens, you see that the pulse is very strong and is very full. As soon as you press on the blood vessel, it quickly refills. And so there's no delay in capillary refill, and there's a full blood vessel, and therefore you will have the pulse rebounding. A client is also likely to experience ascites. We will come to see ascites and edema when we discuss third spacing shortly. So the client will experience ascites. Dyspnea will go with the tachycardia as a result of pleural effusion within the lungs. And crackles on respiration will also be felt as a result of pleural effusion within the lungs. A full blood volume or a distended rebounding pulse will make sure that your neck veins are outstanding, and that is what we refer to as a distended neck vein. Lab investigation will show that there is decreased hematocrit and decreased hemoglobin. There is a decreased blood urea nitrogen. There is decreased blood concentration or blood osmolarity, and there is decreased urine specific gravity, usually less than 1.080. All these decreases are happening because of the excess plasma volume. And as we've said, hematocrit is 45% of the total blood. When you have more plasma, this hematocrit goes down to about 15 to even 10%. And that is why you begin to see decreased hematocrit levels as compared to normal whole blood. In lab investigations. You begin to see a decreased BU, and due to dilution, you begin to see decreased blood concentration or decreased blood osmolarity, and you will begin to see decreased urine specific gravity. The urine will be very light, and the urine specific gravity will be very decreased, less than 1.080. What you want to do for your patient is, because of his difficulty breathing, you want to put such a patient in a high Fowler's position. You also want to pass a urinary catheter to facilitate urination. And you also want to monitor intake and output strictly. You want to administer diuretics, or what we call water pills, so that the patient can easily pass urine and easily lose excess fluid in there. You also want to administer oxygen where breathing is very difficult and very fast. You also want to provide meticulous skin care to your patient due to the nature of his thin skin. You see, as blood begins to accumulate in the body and under skin tissues, the patient's skin begins to become lighter and lighter, and the patient bloats, especially when there's edema on the skin surfaces. What you want to do is not to break the skin and preserve skin integrity. And therefore, in providing skin care, you would want to be very meticulous, and you want to make sure that skin does not break. You would also have to monitor the patient's weight daily, as you do for the intake and output. And you would want to notify the physician where weight gain is above 1 to 2 pounds within 24 hours or 3 pounds within a week. What that will imply is that third spacing or fluid accumulation in cavities is happening at a very fast rate. And therefore, you want to notify the physician so that this is treated before it causes complications. Complications of fluid volume excess may include pulmonary complications such as pleural effusion, as has been mentioned previously, skin breakdown, as was just explained, heart failure, because you put excess pressure on the heart, and the heart begins to work abnormally at a higher rate, and therefore may result in heart failure. And you may also want to look out for cerebral edema, because fluid may leak into cerebral spaces and lead to cerebral edema, and also associated complications of cerebral edema, such as forgetfulness, dizziness, sleepiness, confusion, etc., etc. Third spacing. Third spacing refers to the shifting of fluid from intravascular compartment to extravascular compartment in the human anatomy. Simply put, is the movement of fluid from the blood vessel to other cavities and spaces within the body. These spaces include lumens of other organs, body cavities, etc., etc. Third spacing is mostly common at peripheries, but may occur in any cavity of the body. So third spacing may occur on the feet and on the hands, or on the skin surface most commonly, but may occur anywhere within a body organ or within a lumen, as long as there is space for fluid to leak into. What happens in third spacing is that there's something we call hydrostatic pressure. You would have heard it from your anatomy. Hydrostatic pressure refers to the pressure exerted as a result of the pumping of the blood by the heart. If you didn't hear this in anatomy, you may probably have heard it in physics. So this pressure is resulted from the pumping of the heart consistently pumping the blood. What happens is that this hydrostatic pressure ensures that blood continues to flow throughout the blood vessel and even through the veins. Remember that the vein has valves that prevent the backflow of blood. What happens in third spacing is that as the blood gets to capillaries, you know that capillaries are 1 cell thick or very thin as compared to blood vessels, and therefore fluid can easily leak. When it gets there, fluid begins to leak out of the blood vessel. It happens to every normal human being. But what happens in every normal human being is that there is something we call osmotic pressure. The osmotic pressure exerts on the fluid, leaving the capillaries, and pulls in the fluid back into the blood vessel. As we did for colloids, colloids ensure that fluid from third species are pulled back into the blood vessel. What happens is that due to the oncotic pressure within the blood vessel, high oncotic pressure within the blood vessel, immediately fluid begins to seep out at an abnormal rate. Fluid is pulled back into the blood vessel, and therefore ensuring that the blood moves freely back to the heart. Where oncotic pressure is low or non-existent, you will begin to see that as the fluid leaks out, nothing pulls the fluid back into the blood vessel, and so third spacing may occur. Other things that may result in third spacing may be non-existence or malformation of lymph drainage. And therefore, when lymph drainage gets to that aspect of the body, you will see that fluid will begin to leak into cavities. Third spacing is usually referred to as edema, but may have a different name as per the location it occurs. Edema may occur on the face and on the hands, as well as the legs, and on skin surfaces. When edema occurs in the lungs, it is known as pleural effusion. When edema occurs in the abdomen, it is known as ascites. Third spacing may be generalized all over the body or may be localized to a specific organ or to a specific cavity within the body. So as was explained, third spacing occurs when oncotic hydrostatic pressure far exceeds oncotic pressure. It may also occur due to poor lymph drainage and increased vascular permeability. And therefore, when capillary permeability is increased, what you will see is that fluid easily leaks out and may result in third spacing. Causes of third spacing may include lymphedema, mostly amongst cancer patients, but lymphedema may also be congenital. That is where the patient has problem with the lymph, and therefore lymph drainage is poor. It may also occur due to damage to blood vessels. For example, when you have arterial bleeds, or you have even a simple hematoma or a petechia, what you see is that blood will come out of the blood vessel in spots. That's for petechia or hematoma. It may come out of the blood vessel and settle just underneath the skin. When you have an arterial bleed, what you see is that large volumes of blood may leak into areas underneath the skin, and this may result in third spacing. It may cause the arm or that specific area of the body to swell, and we would have to treat as blood entering a third space. Clients with systemic lupus erythematosus, commonly known as SLE, may also experience generalized edema or third spacing. You know, in pregnant women, their legs easily get swollen. Leg swelling tends to occur due to pressure being put on the vital organs of the body. When a vital organ of the body, say the kidney, the lungs, the liver, is under immense stress, or even the heart, what you will begin to see is that the legs will begin to swell, and that is third spacing. Prolonged standing may result in third spacing. Prolonged standing may occur as a result of what we call the milking action of the feet. When an individual stands for a long time, vascular permeability or capillary permeability within the legs is increased. And when this is increased, you see that the legs will begin to swell, and this may produce a third spacing effect or an edema of the feet. What you will notice amongst military men who stand on parade for a long time is that they move up and down as they stand to accommodate or to move their limbs a little while and to improve venous drainage in their feet, thus preventing third spacing. Note that for individuals who are not experienced in standing, like military men, prolonged standing may result in decreased circulation to the brain and therefore result in the individual collapsing. Nephrotic syndrome, where there is low oncotic pressure, may result in ascites, which is a classic example of third spacing. And organ failure, as has previously been mentioned, may also result in third spacing. What you want to do for a client with third spacing is primarily to manage the underlying cause. Manage the underlying cause. What is causing oncotic pressure to be less, or what is causing hydrostatic pressure to be far high or far exceedingly high. You also want to look at what is causing vascular permeability to be relatively high to result in third spacing. Furthermore, you would want to elevate the arms and the feet. Elevating the arms and the feet would ensure that drainage or fluid that has accumulated in the feet that is not draining returns back to the heart, and therefore ensuring that the person's heart has enough fluid, or fluid moves out of the cavities back into blood vessel, and therefore ensuring that patient has sufficient fluid within the blood vessel. Also, you want to instruct such patients to refrain from prolonged standing and prolonged sitting. You also want to administer colloids to improve the oncotic pressure within the blood vessel and therefore eliminating third spacing. You also want to administer a diuretic to drain excess fluid. Probably the third spacing is occurring because there is too much fluid within the blood vessel, as seen in fluid volume excess, and therefore fluid can no longer be tolerated within the blood vessel and is hence leaking into spaces. What you want to do in such cases is to administer a diuretic so that fluid can drain out of the body. That is the end of today's lesson. For the next lesson, I want you to take a reading assignment. Read on influenza and the types of influenza, read on tuberculosis, and also read on intracranial pressure. Good day.